Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. Alrighty, I am very grateful and honored to be here with Mike Reiman. Mike, how are you today?
I'm doing great.
Yeah, it sounds like we were just bantering before we started recording, but the headaches and the realities of online education and running a course is not easy. So I'm super thankful for your papers, your courses, your education online. I think it's noisy out there in the physical therapy world for high quality education, and it's hard as a clinician who's busy to do it. So I'm very appreciative of your work and your efforts.
Yeah, I mean, it is noisy, and I almost, thinking like I've been a PT for 30 years. I haven't been teaching and doing courses that long, but you know, it, part of me is, kind of jealous of where the students are coming out. I mean, because number one, they're typically way far ahead of where I was,
Yeah.
but also there's a lot more noise too, right? I think I mean, it's just obviously a different era, and so some of it is the fact that there's so much coming at them. It's again, when I came out, it was pretty much, here's what it is, and there wasn't social media and all this kind of stuff, which overall is a very positive, but it just sometimes needs guidance, I think.
Uh,
So
Absolutely. I always tell students it's a blessing and a curse. It's great
yeah,
that we have so much information, and like when I was 10 years ago, when I was coming out of school, I would never get access to someone like you just putting out new studies and your thoughts. I would never get access to Mike and Lenny and their courses and stuff. And as a lost clinician, as a new grad, as we all are, I was very, very thankful to have that. But at the same time, you get some wackies out there who are saying some stuff that's like so far away from the evidence, and even not even about the evidence, just like theory of proper science as a base. And it's really, I feel bad for patients, I feel bad for students, and I feel bad for new clinicians who are trying to figure this out.
yeah, and we may get into this too, but I mean, it's honestly, it's kind of why I started some online stuff. And I mean, I teach, and I mean, I know that I can't cover everything that I want, so that's why I started online academy. And just I mean, just like, I'm just so impressed with the students. I mean, our students where I'm at, and the students on the academy, and just being good advocates for themselves and being good consumers of their career. And yeah, I mean, it's impressive. And as a clinician that's on the back half of his career, it's encouraging.
Yeah, I completely agree. And I think someone who runs educational courses and knows how much work goes into the online content and the constant keep up, along with your daily clinician duties and your teaching duties, I can't imagine how challenging it is. And I think I'm lucky to have Mike and Lenny on my shoulders who are helping me through that process. But it's exhausting sometimes to try to be a clinician and also give high quality information and read new literature. So there's only a few people, like 10 to 15 people who I really have a lot of respect for and I really value, and you're one of them. So again, thank you so much for making the courses. And I just finished your hip course, which is where this conversation kind of came from. And so yeah, I'm appreciative of all you do.
Well, thank you very much.
And I'd like to kind of dive into this because I think, as we were talking before the podcast, when I just stumbled into gymnastics and ballet and cheerleading, kind of like I work with a lot of elite gymnasts. I was a gymnast. And so I naturally kind of got this population thrown at me because they're like, oh, well, like, you seem to treat gymnasts, so you can treat yogi people and you can treat cheerleaders and dancers and ballet. And I was like, all right, here's what I always do is I'm going to review the evidence. I'm going to go back to my coursework. I'm going to look, back on the textbooks and see what we have. It's like 2013. And I was like, oh, wait a minute. We don't got a lot here. It's all FAI. It was all kind of like immobility. It was all based on acetabular overcoverage and, cam pincher lesions. And I felt really lost as a clinician. And so I took Mike Voigt's course, was kind of the first one on MedBridge that had a lot. He was working with Dr. Bird. And then in 2016, Dr. No's textbook came out with Dr. Kelly, which were phenomenal in terms of like what Mike did with James Andrews and the shoulder was kind of like what we kind of started to have for the hip. And so, but besides that and a few articles, it really wasn't a lot to help the clinicians about like, how do we help these people? How do we treat these people? And then when your course came out, it just seemed to really fill a great void between your evidence and then what you practically do. So I'd like to really kind of center the conversation around the lesser known half of the hips, which is the instability, the dysplastic hip, if you're okay with that.
Yeah, that's cool.
And I guess the first place to start is for many people who are listening is they're clinicians who are familiar vaguely, but how do we define dysplasia? How do we define these things? Like, I don't want to give away your course, but like you talk a lot about how it's radiologically based and maybe not clinically based. And I guess just start there with what it is and kind of like what it presents as.
Yeah. So, I mean, you set it up nice there. I mean, overall, the hip in general is like way behind the knee and the shoulder, and which are all behind the spine, which we still haven't figured out, right? So, but it's, I mean, the rate of growth of surgery is exponential for, and it's definitely slanted towards FAI syndrome, and dysplasia is behind that, and from a literature standpoint. But how it's defined is there is no absolute agreement on it. And so we published so I was very fortunate enough to be part of the Swiss consortium that, where we went to Switzerland, and we, like, I led a paper on how to classify the different conditions, and we came up with 3 conditions. One was FAI syndrome, which was covered by the Warwick Agreement, which I was also fortunate enough to be on. And then we also put in there hip dysplasia and or instability, and we can kind of talk about that. And then the third category was, non-osseous pathology, which would be like things like labral, ligament teres, those kinds of things. And so in that second category is dysplasia and or instability, and we purposely put and or because you can have dysplasia and be perfectly fine, right? You don't have pathology. I mean, you may have a high Bates scale and everything is good. And so, but how dysplasia is diagnosed, which can be different than instability, is it's mostly radiological if you look at the literature, because who's driving the literature is the surgeons, and I mean that's perfectly appropriate. And because those are the ones that are typically addressing this the most, and rehab is behind a little bit. There are some clinical exams that, but typically the radiological diagnosis is essentially measuring how shallow the cup is, and so things like lateral center edge angle, and I won't get too deep in all it, but essentially is how much does the acetabulum cover the femoral head, and but also realizing is that could be completely normal, right? And so for specifically like the athletes that you work with, if they don't have dysplasia, they're probably not very good, right? And so, Mike and Lenny would probably argue if you don't have retrotorsion in your humerus,
Exactly.
you're not in a Major League Baseball, right? And so, like, I only have 90 degrees of external rotation. I didn't play baseball. There's no way. I mean, I'm way too old, but like I wouldn't have made it, right? And so, like, you need some of those things to be successful in that type of a sport. And so, I mean, it's mostly a radiological diagnosis.
Yeah. And again, we're going to have a lot of medical clinician listeners, so feel free to go full geek mode, like the deeper.
Okay.
But yeah, I think that was an important finding that I read about I think it was Mark Safran. I think he's out west, and some other people like Dr. Kalsvart were discussing. The first thing I found most valuable about their papers was that it really had an in-depth, really great anatomy of like the capsulolabral structures of like iliofemoral bands and pubofemoral ligament. And it talked about the same stuff that I think Mike and Lenny got really great information out about, like bands of the middle and inferior glenohumeral ligaments. And I didn't have any of that really in-depth schooling in my education anyways. And so I felt like when I first understood the anatomy really well, and then they talked about, lateral center edge angles or anterior center edge angles or tonus angles, I was like, okay, I'm starting to see like what these operative notes say and what these radiological notes say. And it made more sense to me. But it's really hard because I think that information is foreign to a lot of clinicians in the everyday environment if they're not really taught about. There's 85 things you can measure on a radiograph, and how do you know what's right or wrong? I think that's the first step to start, is understanding where the surgeons are coming from, to be honest.
No, absolutely. And I mean, I'll be completely honest, is like I tell my students is, if you want to work with hips, go hang out with a certain, well, number one, get well versed on radiography, because how I got my connections every single time was finally getting in the door with them, and then just hanging around them and just being quiet for a while. They put up radiographs, and I go, it looks like a fairly large alpha angle or shallow center edge angle, and just like would start peppering stuff in, and then eventually they would always turn and go like, how do you know this stuff? Right? And so then it's like you got to speak their lingo, right? And you have to be on their page, and you have to consider how they think in their approach. And because if you go in there and talk about PT diagnosis things that like they don't know what we're talking about, and so so you got to be on their page.
Yeah, I agree. And I think I mean, I am friends with Lenny and Mike, but I study how they kind of interacted with James Andrews and kind of these big, legends kind of down there in Birmingham. And one thing was they would sit in grand rounds, they would talk about the medical stuff, they would learn the surgery. And that's kind of why I invested in the textbooks and stuff like that in your courses, because like I, for example, now have two people under this surgical, which we'll talk about later, but one with a PAO and one with just a labral repair. And like the first thing I did was ask for the op report and ask for the radiology reports and then call them and have a fluid discussion about like, did you take it down the rectus femoris? Did you move it? Did you split the bands? Did you do a capsulotomy? And they're like, whoa, whoa, whoa. Like, are you a PT? Like, what are you talking about? And it's not like an ego thing. It's just like, I care a lot about the patient and I want to understand what ranges are not going to be comfortable or not. And so I think when you approach that conversation of like, I'm taking the initiative, I'm wanting to learn, and then you ask questions about stuff, then I sprinkle in like, hey, like, are you familiar with BFR? Like, we usually start around 4 weeks or 2 weeks if it's surgical. Can we do that? And they're like, oh my God, yeah, like that's a great idea. I never thought about that. And so I think that's the ego-free approach with surgeons versus what a lot of PT clinicians do is they kind of kick the door down and they kind of spite the surgeon, and then it leads on a rocky foot.
No, I absolutely agree, and I like that approach, and like I'm very spoiled where I'm at, and so because like we're in a self-contained environment pretty much. I
Yeah.
mean, our patients go to Duke surgeons. They come, I mean, and then those patients come to us, and so like we have access to their entire EMR, their medical record, and we can see exactly what was done in surgery. And then, but even whether I was in this environment or not, is I agree. Going to if you can have access to going to grand rounds with surgeons,
Yeah.
that is invaluable. And if you're not well versed on, I mean, just go in there and sit for a while and kind of take things in and start peppering things in, like you said, and um, caps or shifts. Was it a T? I mean, what kind of technique was it? Because in was it a tenotomy or a tenodesis, and just like simple things like that. And because if you don't know what was done, like how do you know how to do it? I mean, the simple one I always use with my students is small, medium, or large, or massive rotator cuff tear.
Yeah.
Like those rehabs are different.
Yeah.
And if somebody closed the capsule on a hip versus didn't, like I address those things differently. So
Yeah. Yeah, I agree. And I think also in line with that is being able to, I mean, I think I underappreciated until I met Mike and Lenny directly and work with them as mentorship is like how much it impacts their diagnosis and their rehab for them about how they progress, how they pull back, how they kind of put the art into the science of PT. Because like you said, small versus medium or large cuff tears have maybe a same exercise timeline, but they're not going to have the same approach to passive range of motion or the speed at which you progress. And so in some of these cases I have some who have a very, simple, quote unquote, arthroscopic labral repair and no osseous changes, no work on anything else. It's just the straight up labral repair. And it's like, okay, that might be very different than someone who had a labral repair, some microfracture, an osseous change on the acetabular rim they worked on, and like different surgical techniques, and so it's completely different rehab for those two people, even though they're both two anchor slap repairs. And so I think the people should really appreciate how much it changes the rehab. I think that's where maybe people don't put the work in to want to learn these things. Like, should you know if it's an 8 millimeter versus a 6 millimeter, like scalpel technique? Probably not, but you should really be diligent about understanding what the anatomy influences on your PT rehab.
yeah, absolutely. And in full disclosure, and we published in about this, I think in JOSPT 2 last year, is the protocols for hips are all over the place, and that can be very frustrating for a young. I mean, for me, I actually like that, is because my thinking is that it's probably individualized, which is probably not the right thing. But I just think that it's, I mean, biological plausibility would tell you perhaps you limit extension and or external rotation for an anterior labral repair. But some people don't. Some people use braces. Some people don't. Some people don't use braces because they feel like it irritates the psoas, and I've anecdotally seen that. And so sometimes, so as a more experienced clinician, I like the leeway in a protocol versus the distinctness.
Yeah.
I think the other thing that happens is when it's very distinct, people follow that too rigidly versus like, okay, maybe this person needs to speed up a little bit or slow down or whatever. And so, yeah, I think it's worth mentioning that protocols are a mess as far as post-hip arthroscopy. So,
Yeah. And do you feel that's because the evidence is still just developing? Do you feel that's just the variety in surgical technique? Do you feel as though it's kind of like, we had this with low back, then we had it with some other conditions where it's like we don't know what we don't know, and then the evidence evolves. Like, what do you think the variability in protocols comes from?
Yeah, I think it's probably a combination of a lot of all of that. And so I think we're just simply behind on the hip as far as literature. I mean, the rates of publications are exponentially getting higher.
Yeah.
Luckily, we're starting to get more randomized controlled trials, and there's been a published um, study where they did an inert effect, and so we're getting there. And but what's interesting is, like, it doesn't seem that we're using some of the things that we've learned in, like, shoulder, like subacromial impingement, and like, why don't we follow some of those concepts? And
Yeah.
yeah, I think it's just we're just behind.
Yeah. I would agree too. And I think on the kind of taking tools from other people's tool belt, like the baseball world, is something I've been lucky to get with Mike and Lenny, is like watching them how they treat an unstable shoulder and just kind of applying some of those principles. Like, there's probably no RCT gold standard on like, should we use EMG or should we use some stim for the hip? But it makes clinical sense that maybe putting some stim on the glute med after surgery and doing rhythmic staves, if it's cleared, might be a great idea. BFR is another example. Like, there's a lot of examples of things you can kind of clear with the surgeon, make sure they're okay, ask their ideas if you build trust, and maybe get ahead of the research a little bit. And then that sparks more projects down the road. I think a lot of that's how a lot of evidence comes to be, is clinical intuition and ideas. And then it kind of gets validated,
Yeah, it's when I was doing my PhD, we always talk about, clinical practice is always going to be ahead of evidence, right? I mean, there's always going to be people pushing the envelope from a rehab standpoint, and good or, I mean, that's just the way it is. And so, like, it's going to take a while for evidence to catch up. And and so then it's we just have to be cautious on interpretation of some of that stuff. But the other thing is, why not use things? I mean, like, that was a good example. Stability concepts are going to be the same relatively in the shoulder. I mean, obviously there's differences, but some of the general concepts are going to be similar. So
Yeah, absolutely. And I think the best way to start this, because I know obviously it's a lot of information we want to cover, but I guess we kind of talk about the radiological diagnosis, but let's talk about maybe like clinically, like in your experience, what's the type of population who's coming to you with this diagnosis, and like what are their on the top of the exam subjective stuff? Because that's always the most important, is to have a good subjective history.
yeah, so there's not a lot published on it, but so this is kind of more somewhat evidence, but anecdotal from my standpoint, is they tend to have mechanical symptoms. So very similar to, I mean, could be FAI, but they tend to have more same kinds of things with the shoulder. It feels like it doesn't pop out of place like it does in the shoulder, but it feels, they won't typically use the term unstable, but it doesn't feel right. And it feels typically motions of extension or external rotation, or, like somebody that's batting, it's their back leg and it's pivoting, or a golfer and it's loaded in extension and external rotation. It kind of feels like it's shifting and or giving way. I feel like I have had a few people feel like it says it's popping out of place.
Yeah.
That typically tends to be more of a snapping hip kind of a condition,
Yeah.
which could be with some instability as well. But they don't like prolonged position. I mean, a lot of the same things that you learn from the lumbar spine and the shoulder, and they tend to be high on Baten scale.
Yep.
And or they tend to be specifically to certain activities, like the individuals that you're working with. Yep. And those tend to be the bigger things. They don't come in and have even like the people that are micro unstable, they don't rim load and they don't shift out like the shoulder would, because they're, it's more load bearing. So
yeah, it's really interesting. I think, I obviously come from the typical population of that, but the more that I read and the more that I thought and the more that I kind of listened to you and other people, it was interesting to me, because obviously Mike and Lenny treat a ton of baseball players, and then Mike Scaduto at our clinic treats a ton of golfers. And this concept of microinstability started to become more plausible, of like, well, maybe we're dealing with, microinstability in the back leg, like you said, in the extension rotation. Whereas my understanding of it is that there's, like, you're fulcruming out of the femoral neck on the posterior lateral acetabular wall, and it maybe is tipping the anterior femoral head forward. And the thing that was really kind of like an eye-opening moment for me is that so much anatomy is layered on top of each other. Like Peter Drayovich's concept is like, you have the femoral head, the iliofemoral capsule, and the labrum, and then you have directly like psoas tendon, you have rectus fem stuff, you have adductors, you have a lot of layers of stuff in a very small window, along with bursal tissue and neurovascular. It's like, how in the world do you know where it's coming from. Like, that's such a hard thing for clinicians to do, is like, is it more muscular? Is it more intra-articular? So I'm not sure if you have insight into this, but in that population, because I think people think like cheerleader, dancer, super flexible circus person. They don't think about a baseball player, a sprinting athlete, a rotational athlete. So it was your experience that there are more people maybe in that traditional sport that are having these instability issues?
Yeah, I think, well, number one, I think classifying instability is challenging.
Yeah.
And so, but yeah, I definitely, I think I see those people. I think, it's like, for example, I had probably one of the more recent, I had a javelin thrower,
Mm,
that it was his back leg, and it would inconsistently, what he would say, catch and or pinch on him
yeah.
with an extended externally rotated type of a position. And it got to the point where it wasn't, it didn't happen every single time, but it happened tend to be the harder and the more range of motion he went through.
Got it.
So it started bothering him, which normally, and so he mentally would shorten up so he would change his technique,
Mm,
and he was throwing shorter and shorter. And the coach came and talked, I mean, he was getting rehab, and coaches going like, why is he throwing, and why is he shortening his stride? And so I had to talk to the coach, and coach said, well, he's shortening his stride. And so we would have to work on progressively getting back to that. And I think part of that, I mean, it's a challenging diagnosis. And I mean, there are tests. I mean, and they essentially, anterior instability is much more common than posterior. Posterior tends to be more macro traumatic versus micro. All the anterior tests try to bias and or fulcrum and or load the anterior portion of the hip. And so, I mean, if you look at the anatomy, as you were alluding to, is the psoas runs directly in front of the labrum and the capsule, and you have the iliocapsularis there. And so, like on a right hip, if you put a right hip there and you did a clock face on it, kind of 12 would be superior, 6 would be inferior, 3 would be anterior, and 9 would be posterior. The original studies were finding that labral tears were mostly kind of this 12 to 130, so kind of anterior but mostly superior position. And the theory was, a compression mechanism like with FAIS.
yeah.
And then now, like Benjamin Dome has published a lot on this, more these 3 o'clock labral tears, which are more anterior. And part of the theory, and again, this is theory, is that it's, loading that, the femoral head is, kind of rim loading and pressure loading. And so it's putting pressure on the psoas and the capsularis, and it's just kind of causing this repeated micro tear kind of episode. And I mean, you do see in the literature that they're reporting more of these anterior labral tears. And so, is that as a result of, progressive overloading anteriorly, or
Yeah.
possibly? Yeah.
Yeah, and I wonder this too, like trying to take concepts from Mike and Lenny, especially like the work that they did in the shoulder. Is I have always theorized in the shoulder, we talk a lot about in the clinic about how somebody can be stiff and loose at the same time. Like, you're going to be stiff from a muscular tendinous point of view from repetitive training and repetitive movements, especially with like, how much the adductors are active in sprinting or how much the rectus fem is active in some other things as well, that you can accumulate soft tissue stiffness, but then have hypermobility that becomes instability when you are compensating for that lack of mobility. So in my head, I think a lot about like maybe they are stretching out their iliofemoral bands more, and it's starting to pull on the labrum a little bit because they lack a lot of motion or they don't move well or whatever else it is. But I don't know, do you share that idea? Because I think there was a study that showed that like a biting was correlated to more femoral head motion under anesthesia. And then there was another one I just read about fresh frozen cadavers where they actually did put them under tension for a long period of time, and they had significantly about 5 millimeters more of motion under anesthesia, dead. But I don't know, do you have that theory too? Do you think differently about how that might happen with a 3 o'clock lesion, or no?
Yeah, I think it depends on if is this somebody's post-surgical or non-surgical, because if you look at the older literature, and some are still doing it, is like when they would go in there and open the capsule, they wouldn't some of them wouldn't close it, and
Right.
then they would also release the psoas,
Yeah.
and then we would wonder like, why are all these people lax? And so so now, but if you talk to the really good surgeons, and like surgeons I work with, and a bunch of Philip, I mean, all the good ones,
Yeah.
they're saying you have to close the capsule and try not to release the psoas. And I mean, the reason it's red on the backside is that's not the reason to cut it. I mean, it's to try to figure out why. And so, yeah, I do think that Well, and the other thing too is remember, like, especially in the hip, those ligaments are all just thickenings of the capsule.
Right. Right.
And so, in all, I mean, if you look at the biomechanics, is all three of those primary ones, iliofemoral, pubofemoral. I mean, all those ischiofemoral, they all get stretched with extension, or they all get tensile loaded with extension.
Right.
And so, but I will, and so like if you see somebody with a lot of extension, yeah, I mean, then I'm okay. Where is that coming from? Is it a layered approach or whatever? And I
Mhm.
and I do think I see, like, I'll get people and put them in a Thomas test, and like everything up to that point has been telling me like they're lax. I mean, high on Bain scale, subjectively, like all this stuff.
Yep.
And I do a Thomas test, and it's like 30 to 40 degrees from the table.
Yeah.
But then if you do some controlled contract relax, like they start dropping down.
Right.
And so I don't know if it's kind of the same thing that Lenny and Mike are kind of talking about, but like I do think, is it tight, or is it protecting? I don't know if that's the right word, but like I can, like, those positive Thomas tests, like I can get them to drop down quite easily just with contract relax or getting them to relax or whatever. So,
Yeah.
so that might go along with that.
Yeah, I agree. Again, it's theory. It's anecdotal. It's just from the people that I work with that, make lots of money off of hyperextending their hip really, really far. And I think it's funny you mentioned that about, some people can have dysplasia and be completely fine. Mike always makes the joke that like these loose jointed people, their jerseys on the wall made them millions and millions of dollars if they didn't have this. So when the kids come in and the doctor's like, well, you're loose jointed and you're going to pop out. It's like, dude, people make millions of dollars off laxity. And that's where a lot of sports come from. So I think that's what's sometimes missed by some doctors that I work with that are just like gymnast check, loose check, go PT. Like you're just loose. That's what it is. It's like, I don't know if the dysplasia equals instability, which equals pathology. So that was my next question is how do we differentiate between normal dysplasia versus hypermobility versus like pathological instability and issues? Like where's that line there?
Yeah, that's a great question. I wish I had a great answer. I like I do. I mean, I agree. Physicians do the same. I mean, I get the physicians doing the same thing. I think sometimes PTs, and early in my career, I think I did the same thing as well.
Yep.
It's a gymnast where you're lax versus that's what got. I mean, that them having that amount of motion is what is making them successful.
Yeah.
And the example like I always give is a large femoral head, so FAI impingement, and that tends to stop growing when the growth plate is closed. And so and if this is a 25 or 30-year-old athlete, that they've had that for 10 years. Why are they having problems now? They've had problems for 2 months. And so the easy blame is, well, it's the femoral head. I can see it on the radiographs, right?
Yep.
Or I can see the shallow hip. But yeah, they've had that for a long time. Why are they having problems now?
Yeah.
And so differentiating that, so like I look at Bain scale, I mean, and look at it overall. That said, is you could have probably not in the individuals you're seeing, and they're probably high on Bain scale, I would assume. Um, but it's muddy, and like I look at subjectively, and I think it's important to differentiate hypermobility versus pathology, right, or instability. So if they're just generally high on Bain scale and they have a lot of motion and they don't have pathology, I mean, then like if you look at ballet dancers, there are studies that show that I think 90% of them have a snapping hip, but they're all asymptomatic.
Right.
And then some people would argue, well, that sets them up. Well, I don't know. I mean, maybe, but I think the big thing is symptoms, and that symptoms that are consistently with same types of movements.
Yeah.
And in that case, then I'll just, like, I can't change the shallow hip. I can't change the fact that they're going to do ballet. What I can change is the magnitude of the motion, the intensity, the stances with different activities, and try to gradually get them back to those activities. So
Mm. Yeah, and I definitely like what you mentioned there about the is it part of what makes them successful and stuff like that, because I again, the name escapes me, but I remember reading a study of ballet dancers that were asymptomatic and they radiographed them in middle splits on a table, and the average was like 5 millimeters of subluxation of the ephemeral head that everybody had. No pain, no problem. Professionals making a lot of money off their hips, and it was like, I think that if you were to see that finding stripped away from the other evidence, you'd be like, oh my God, they're slipping, their hips are out of the socket. It's like, well, maybe that's necessary. You know what I mean? And a lot of times we see with the baseball guys, they come in and they have 110 degrees of layback because somebody was nervous to stretch them way back. And Mike's like, this is bad, man. If you throw a baseball, we're going to have a big problem here. And so like they're working to get that really large motion back. But I think that intimidates a lot of clinicians. I think that really large range of motion, if you don't understand the sport, is very scary to a new grad or someone working on a non-surgical or surgical hip. So it's challenging, but you have to realize what are the sporting demands, I guess, is what I'm talking about in the subjective eval.
No, I absolutely agree. And to be honest, like I was there, right?
Yep.
And my big thing early in my career is like I was seeing a lot of ACLs. And I mean, just a kind of a quick story where it made me kind of like, duh, is I had this athlete that was just smoking through rehab and doing really well. I mean, it was mostly due to them.
Yep.
And then it was, we got to 9 months. We didn't have isokinetics.
Yep.
We had handheld dynamometry, and he passed that. And then he passed to KT Lockman's, and the surgeon released him, and he kind of came back, and I said, "Well, you're good." And he goes, "Dude, I'm a wide receiver. Like we haven't run any pass routes. We haven't like, how do you know I'm good?" And I thought, you know what? He's right. We haven't looked at. I mean, we did hop tests, but like we didn't replicate his sport demands, and so in kind of long story, I mean, that's what prompted me to write my first book on functional testing with Mansky is
Yeah.
like, what's out there? I mean, versus like just like what does he have to do and can he do it? So
Yep. Yeah. Well said. Well said. There's a lot of different, and we could talk on that for an hour alone. But I think that kind of, in my mind, is a really good subjective. But in the clinical assessment side, you mentioned like, a Thomas test, you mentioned some instability tests. What do we know, I guess, moderately from your course? I don't want to give it away, but we know from the literature that maybe is a good indication of these people who are more pathological instability with these tests versus those maybe that don't fall into this category.
yeah, so I mean, there are a few tests, prone instability test, which is kind of what it sounds like. Is you kind of put them in prone, and I even at bias extension, which is not how it's reported, but you try to get on the posterior portion of the greater trochanter, you essentially try to orthokinematically glide the femoral head, which is very hard. But then you also try to osteokinematically. So you essentially try to tensile load the front,
Yep.
and it has fairly high, good likelihood ratios. The problem with all the studies are the same problems with the FAI studies is they're typically done in like surgeons' offices where you have a high pretest probability.
Right.
And then also you have not very good control. So some of these studies are lower quality studies.
Mhm.
Does that mean they're bad tests, or or is it just the environment? Like I still utilize them. I still try to stress extension and external rotation in these individuals.
Yep.
I like putting them in Thomas test and doing kind of cranking into extension and external rotation. So kind of what's called a HERE test.
Mhm.
And kind of looking for apprehension. That said, is some people that are not blatantly unstable, like you have to kind of replicate their positions. And so like if they're batting, I mean you can't replicate, and so like I'll get them go through the motions, and I'll like try to push them more into extension
Yeah.
and see if that bothers them. So it's almost kind of a overpressure of that position, and that's typically how I tend to look at them. And then all I do is just try to scale them back and shorten them up and progress them from there. So
Yeah, and I can definitely mirror that on my side. Is I think like the side lying hip extension test with the glide is very specific to what a lot of people I see, which is like gymnasts, dancers, ballet. They're doing splits. So especially if they can hug the front leg and kind of put them in a posterior,
Mhm.
it mimics their split pelvis position, which I think is really really valuable as a clinician to kind of do. And I think usually, as you said in the course, and as many people have said, well, is like you're 60 to 70% of the way there by a good subjective examination, and then you're kind of just confirming to yourself about what you think is the place to start on your clinical exam. And I think that for most people, they understand like this person is in the instability category. And then they're like, all right, how do I help this person? Right. Because I know my FAI classic hypomobility, maybe like, how to address that. But I think on the other side of the fence, they're really confused about like, where do I start with someone who's trying to avoid surgery and, is maybe got to get back to a really aggressive sport? What are the first couple treatment options that you said, like modifying what they're doing is obviously important, but like on the actual clinic, what are you doing with people early on to try to either help them with symptoms or build strength? Like, what are your thoughts there?
yeah, I think it's so number one, you got to be patient and you got to involve and you have to involve them, right? And so it's like I think, and I've done this early in my career too, is the tendency is to kind of dictate what you want done versus like, in like, if you look at our studies is as far as compliance and expectations, like they're poor, right? And well, I mean, well, do they want to do that, right? And so definitely getting the patient involved. And in the course, I talk about general thing is like keeping things simple, not trying to do too many things at one time. I use like I use the acronym of what I call EPIC return, which essentially is EPIC. So giving them education, maybe on the condition. Like I don't catastrophize them. I don't like show radiographs and just say, what, your hip is sensitive with this type of a position. You've been doing that for a long time. You've only had problems for 2 months. I think that you have a good prognosis. We need to probably scale some things back. So again, like shortening the range of motion, changing stances, maybe using, like if they're doing squats and they're bothering them, shorten the range, have them do box squats and use time under tension. And so, because you have to keep loading them,
Yeah.
and you have to kind of figure out, okay, how do I keep loading them without them losing interest, and or them, because if they're athletes, they feel like they need to feel tired and good exercise. And
Yeah.
so I think time under tension works really well. I mean, just slow the time down and then shorten the range of motion up can be, and we can talk more about that kind of stuff too. But so that's part of progressive, overloading or loading and just making sure is, what's the load on their system, and addressing them from a biological, psychological, and social standpoint is, if you look at hip patients and even dysplasia patients, is the literature is more strong on FAI because we've looked at it longer, but the majority of these people have had pain for 2 or 3 years.
Right.
These people are frustrated.
Yeah.
And if you look at some older studies, and I hope this is getting better, but the majority of these people have seen like 2 or 3 providers, and
Right.
this has been over 2 or 3 years before it's actually been diagnosed.
Yep.
And so they have some relief. Okay, it's dysplasia or whatever. Now, what are we going to do about it, right? And so I think acknowledging that is very important in addressing that. And so, I mean, from the individualized is like, what sport are they going back to? What position do they play in? If it's a gymnast like you're working with, or is it somebody that's batting and it only hurts when they bat, or the javelin throwers?
Right.
Okay, like, can we just do partial throws, and what other things can we still do to, then the other thing on my epic return is C is what's considerations of you as a clinician. What kind of experience do you have? Is it better to go to somebody else? I mean, like, if you look at some of the ACL studies, like, 55% of people, from a JOSPT study from Greenberg shows 55% of people used manual muscle testing or strength testing, manual muscle testing as a determination of a return to sport.
Right.
Yeah, I think we would all agree that that's not adequate. And so, I mean, because I get a lot of patients that go to see the surgeon I see, and they come from other PT clinics, and I just don't think we're not doing the basics really well. And so, that's part of considerations. I mean, even in the environment area, and if you're in a seventh floor building and you don't have any place for them to run or jump or that kind of stuff, like, are you going to go meet them on Saturday on their athletic field and do those kinds of things? So, I think there's a lot to it.
Yeah, I agree. And I think the two things that kind of stick out to me, one is it's amazing. Again, I've learned this from Mike and Lenny. It's amazing how when you talk about their sport, you use their terminology, you ask specifics about what bothers them in their sport. Like, you have to take the initiative to actually talk their lingo, because that builds trust, that builds buy-in, that builds a rapport with them. But the other piece that you mentioned so well is, like, these people are typically high active. They're athletes. They want to feel like they're doing something. And there's always a role and a time and a place for basic, really low level thorax, especially post surgical, if someone's really having a tough time and they're sensitive. But you got to quickly get somebody into an athletic mindset. And I think that's where the role of things like using STIM early on, using BFR early on, finding really understanding and knowing strength conditioning to be like, can we make more hip dominant loading versus directly maybe something that's provocative? Maybe they can get away with a split squat instead of a regular squat, and they can load that a little bit more, or a step up on a low box, and feel like a training effect. Like, wow, I'm actually working here. I'm here sweating a little bit. Like, I'm getting to work on. I think that that's so valuable to people because they feel as though they're not broken. They feel as though they're not like pulled away from their team. They can't do anything. So if you can get in their head and understand what they're going to, maintain their workload, which we know from other literature studies is very important to get the return back, and then also give them things that are actually challenging. That makes a world of difference for that person's mentality versus like the I'm broken, I can't do hard exercise, and then they start to develop this I'm scared to use my hip because I feel like it's gonna have a problem.
Yeah, absolutely. I mean, one of the big things is, granted, I see some fairly challenging cases just because of where they're coming, from the surgeon they're coming from, and it's always like guiding them and encouraging resilience and telling them, what, you're just sensitive in that position. I mean, you've had this dysplasia, if they're, I mean, you've had this for a long time. Like, why are you having problems now? And kind of like that first session is spending a lot of education on it. Is, prior to 2 months ago, you were doing well.
Yeah.
What changed in that amount of time? And sometimes they know, and sometimes they don't. And the other thing is, we're not taking things. I mean, it's like I almost treat them kind of, like if I used to work a lot with runners, and if you tell them they're not going to run, like they're not coming back,
Yeah.
right? I mean, and so like all my patients still squat, and like you said, is we might be front rack squatting, or we might be squatting in a Smith frame, or we might doing box squats with time under tension. We might not be doing a low bar back squat, to parallel
Yep.
right now,
Yep.
and then we're going to kind of gradually progress it, and using like RPE times time or load, or I mean, kind of getting some kind of auto regulation as well,
Yep.
and learning how to systematically progress that over a period of time. And sometimes we change stances, maybe not so much but like FAI patients, oftentimes going out to a sumo squat.
Yep.
Some sumo squat studies are showing that actually puts a little bit more load on an unstable patient. So like I tend to play with that and see. But then, and I still do this sometimes, where I'll change some things, and they'll go, well, this is not what I'm doing, what I need to do in my sport. And I
Right.
know we'll eventually get there. Is my goal for right now is to keep the intense and the load on you.
Sure.
And I've explained that, to keep the load on you and then we'll change the position. We'll lower the load down, and explaining it how we're going to progress them through that. And because I think they need to understand is, this is not a setback. This is just, we're going a little bit sideways right now,
Right.
and then we're going to still get back on, or we're still going forward. And the other thing too is sometimes the rehab takes a while, and I think what gets challenging, for like a lot of times my students will email me or talk to me and say, yeah, come seeing this patient, and this is what's struggling with, and people are plateauing, and they're like, and I said, well, are you doing this? And they go, yeah. And I mean, sometimes I think the problem is, if when people plateau, is you're trying to figure out, am I still doing the right thing, or do I need to change things up, right? And so I think that's where sometimes being in an environment like you're in, and having somebody else, hey, Lenny, can you come and look at this, or and just, I think being in an environment where you can have somebody else take a look at it, and or consult with somebody is very helpful too.
Yeah, I'm really happy you mentioned that point because I think sometimes people get the perception that, people like Mike and Lenny or people of your stature kind of like don't ever ask for help or they don't ever ask for a second opinion. And I mean, I'm 8 years out right now and I have really great mentorship. And it was like 3 weeks ago that I had a guy who had a very high level throwing athlete who like his elbow just wasn't getting better. I thought it was more of like an olecranon impingement and it wasn't going well. And so I was like, Mike, do you mind just taking a peek at this? And Mike was totally open. It wasn't weird. The patient didn't think I was a bad therapist. I'm like, I just want you to get better. And I need another set of eyes. And sure enough, Mike was like, yeah, I think it's more triceps tendinopathy. Let's go with this approach. Try this. Person's getting better. I feel I learned something. Mike was happy to help. And it's like finding those relationships where somebody can, in an ego-free way, be able to help is really valuable. And I've done that with a lot of people on, my expertise of hips and backs for Lenny and Mike in the opposite direction because they didn't have the experience. And it's not anything. It's the culture you build and the people you surround yourself with to be like, hey, what do you think about this? Or like, hey, I'm struggling with this or whatever else. Like, it's just so important to sacrifice and go out of your way to find those environments. That's my biggest piece of advice to new grads.
I think I absolutely agree. I think students and young clinicians I mean, they feel like they have to know everything, or they feel like they are admitting failure. I don't know if that's the right word, but like I consult, like I'm in a training room right now, and there's like, I mean, even though I'm an athletic trainer, like some of the taping things, like like I'll go ask a trainer, like, what do you think we should do with this?
Yeah.
And yeah, and I think part of it too is being comfortable with uncertainty, which, a lot of people say they are, but they really aren't. And it's just, and being genuine with your patient is, what, in that case is like, we've tried these things. It seems to be stalling just a little bit. I mean, do you mind if I just get a fresh set of eyes on this? And in the meantime, you've been getting a good therapy alliance with a patient. And I think patients generally appreciate that.
Oh yeah.
And I think it's how you sell it though too, is right. I mean, if you go in and go, "God, I have no idea. Like, I'm gonna go get somebody." Like that's not the way to sell it. But it's, yeah, I think, every year I give my students I think it was Simpkin that wrote it, is tolerating uncertainty.
Yeah.
And just, I always give them a talk about appreciating the gray versus the black and white. And that's part of it. And I think it's just being comfortable with being uncomfortable.
Yeah. I really enjoy that approach that you said is how you present it and stuff. I think the perception, again, what new grads, what I used to think, the perception from the client is that this person doesn't know what they're talking about. I'm an idiot and blah blah blah. And you think they're going to be insulted, when in reality, most patients are grateful. Most patients are grateful that, like, wow, this dude really cares about me. This girl really cares about me, that he's going to talk to this surgeon, read this new paper. I think that was something I used to do as a new grad, is I would leave out all the research papers that I was reading on my desk as my clients walked in. They were like, "What are you doing?" I'm like, "Oh, I'm just reading up on this textbook. I just went back and revisited the protocols. Like, I was talking to somebody else about it." And I told these patients that I have right now, I was like, "Yeah, I just finished a hip course and I learned some new stuff. And I tested somebody this way. And then I went back and read the videos. I was like, oh, we're going to retest you on the MMTs or the dynamometers this way." And people are like, "Wow, this person cares about me. This person is willing to have an open mind." And I think being able to admit, one, that you're always learning and you don't know, but also two, is when people see you admit that you want to maybe get a fresh set of eyes, it's opposite to what you think, is that they're actually more valuable if you present it in a way as like, "I have no idea what I'm doing, and I watched a YouTube video." That's not what you want to say. You want to say, like, "We have a good group here. They've seen a lot of these things I maybe haven't, so we're just going to try to do whatever we can to help you."
Yeah, absolutely. I mean, it's just, you and I were talking before, I think we went on, and just, about being in a good environment. And, before I started teaching, is like I was in this clinic where, like, we just had good people there. I mean, they were generally interested in being better. And like we were in an open gym kind of area, which I think you guys are as well. And it would be, I mean, like we'd razz each other. And it would be like, "Man, this guy's struggling. And hey, Joe, do you mind coming here?" I mean, it was so open
Yeah.
that patients were, every once in a while you get somebody like, "Why is he coming over here?"
Yeah.
But I mean, you kind of read that when your patient is like that. But it's, yeah, I mean, it's like, where I teach is like, I'm in a hallway with one of the world's expert on vestibular rehab, and Chad Cook is a couple of way, like I pop in their office all the time. I mean, just like, "What do you think about this?" Or, I mean, new studies or what. I mean, it's
Yeah.
very refreshing.
Yeah, we have that open dialogue as well. I think there's twofold. One is that, our 5 desks are all connected, and I have Mike and Lenny on one side and Dan's down the way, and Mike and Lisa. And it's just like, "Do you hear about this? What do you think about this?" But also just, it's just osmosis, right? Like, I watch, all of us are constantly learning and thinking and seeing different patients. So like, I'm watching Dan do, powerlifting programs with these advanced athletes, and I'm watching Mike work on rotational swings and stuff. And I'm like, "Huh, I never thought about that before." Like, "Oh, what are you doing over there?" Like, that's pretty interesting. And so, like, an example yesterday is Dan's got a couple Achilles ruptures patients, and I'm watching him do exercises I've never seen before. I'm like, "What do you?" He's like, "Oh, I watched Cal Dietz do this one, and I think it was really cool, so I modified it." And I'm like, "Oh, I like that a lot. Like, it's pretty interesting." And like, whether you're directly having discussions or just like watching the flow of a daily environment of 5 strength coaches and 6 PTs, it's phenomenal. Like, it's a free Con Ed course every single day, and I'm very grateful for it. But I feel bad people don't have it.
No, yeah, I agree. And, it's, the nice thing about that is you see the exercise, but then you get the theory on why they're doing that, right? And that's like always my first question is, well, what's the goal, or what's the objective here? And yeah, I mean, it's challenging because, I teach, graduate students, and like they all want mentorship, and they should.
Yeah.
And so employers are always saying, "Well, yeah, we'll give you mentorship." And I tell them all the time is, what does that mean?
Right.
Does that mean Friday, as they're walking out the door, they're saying, "Mike, how was your week?" Or are they, are you doing journal clubs? Or, I mean, are you setting aside at a time? And because, I think the other thing too is, I think I don't know if you're familiar with Simon Sinek, but he
Yep.
talks about how, and he's not talking about PT students, but young people are like changing jobs because they feel like they're not making a difference in their job. And like my daughter is kind of in that age, and she's kind of the same way, where I can see, like when I was her age, I was just like, I just want to get through school and figure out what's going on. And like, I mean, they have huge goals, and like they want to be profound people, which is awesome. But if that doesn't happen soon, Simon Sinek was talking about, they want to get into a different type of a position or different change, and they see Mike, they see Lenny, they see Chad Cook, and like, I want to be there, and they don't realize that it took Mike and Lenny and Chad Cook, and like like I mean, I think Mike has mentioned this too. Like I failed my ATC exam the first time.
I got kicked out of PT school.
Did you really?
I did. I failed a clinical.
Wow. And so it's like they see us where we're at versus like what we've been through, right?
Yeah.
So, yeah, and so it's like we just, I mean, I very much appreciate how they want to be great and awesome, but just realize that sometimes it takes a little bit of time. I mean, some people, and then the other thing is they see some people, like we've had graduates that are like they're in the NFL within a couple of years, like, and then so I tell them that story and they go, well, he's in the NFL and he's 2 years out. Like, okay, yeah, those things happen too. So
Yeah. I think I always make the joke with people that, I sacrificed mentorship for proximity of location and money. When I was an early grad, I was like, these loans are heavy. It's closer to my house. Like, I'm just going to take this job because they said mentorship. And it is exactly what you said. It was like a part-time casual interaction. It wasn't real mentorship. And so the advice I always give the new grads is like, take a little bit of a less pay, more travel to get someone who's really going to help you. And that's why I would have changed jobs, obviously, for many other reasons. But one of them was that like Mike and Lenny are treating clinicians. They're in the trenches. They're always happy to help. They're learning. They're pushing themselves, but like they're never afraid to, give some tough love sometimes and be like, hey, like maybe think about it this way or not. And I think like that's invaluable compared to anything else that you can get in another clinic. And so if I could go back and do it over again, I would sacrifice those two things for the mentorship. And I think people should maybe take it to heart, especially as we get into new grad season coming up here.
yeah, I mean, we have a lot of students that go on to residency. I mean, we like it's proportionally high, which is awesome.
Yeah.
And I mentor in our fellowship program, and and it's, to be honest, I think the best mentees or residents or fellows are the ones that have actually been out a while and
Yeah.
have seen a few patients, because then they can ask different questions, right? They come in and say, you know what, Mike, I've seen 10 FAI patients, and I'm struggling with this aspect.
Yeah.
The problem is like life moves on. I mean, you move on with life, and so it's just more naturally set up to go straight into it. And so, but yeah, I mean, that's just the nature of life, right?
Yeah, and kind of tying this together, I think when I think back to what I struggled with the most in new grad, especially like asking for help, post-operative in general was very, very intimidating for me, especially because I feel like I didn't have the best education on that first kind of 2 weeks. It was very scary, but like a post-operative hip, man, especially one that's got dysplasia underneath it and they have larger range of motion, it is terrifying it was terrifying for me until I had Mike and Lenny's guidance around like, dealing with that 1 to 7 days. And I think for a lot of people that I mentor, I've had, not naming names, but great students we have, I love them to death. But, I have them help me on like a post-op day 3, day 5 hip. And it's like, they're touching glass, they're just terrified to even like breathe around the person. And it's like, yeah, you got to know the protocol. You got to do your homework. You got to understand what's going on. But like, once you understand the surgery and you understand what's going on, like it's okay. We got to help these people. And so I guess we talked about some conservative stuff, but so say someone should have anywhere from the labral repair. And again, I'm seeing some periacetabular osteotomies that are big doozy surgeries. How do you approach or mentor people on approaching that first couple weeks to a month where it's terrifying for a young new grad or even for a seasoned person who just hasn't dealt with hips before?
No, I definitely agree, and I definitely was there as well, and that's kind of what got me all into this. Is I had a patient where I didn't know what to do, and so I started researching and just kind of got deeper and deeper into it. But I think some of the principles are still the same. I think still doing the basics, still keeping it simple. And what I tend to see, and granted, I've done this. I mean, I've made these mistakes too. So, is people tend to go too fast or too slow, and and then the other thing is they tend to follow the protocol specifically, meaning, they're at, like I tell students about, a couple of stories is like they're supposed to be at 90 degrees. So you keep pushing them and now you got this really inflamed and irritated hip. And now they're in, then they're not getting, then they're coming in at, they came in the first day at 85. Now they're coming in at 80
Yeah.
or 75, and you're like, what is going on? And so you keep pushing them harder,
Yeah.
and you just keep going backwards because you're irritating them. I mean, you're like looking at the 90 versus like they're going backwards. Like what is, versus like looking at the big picture. And I think that's part of it, just being overwhelmed with the situation versus what do they need, what's going on, and how do I progress them? And so I think the big thing is you got to calm them down.
Yep.
And so um, the open back position of the hip is typically about 30 degrees of flexion, same amount of abduction and slight external rotation.
Mhm.
I mean, even just simply teaching them when you sleep, if you want to put your leg on some pillows or whatever. Now, granted, some of the protocols are, they need to be on their belly a certain amount of time or doing a CPM. And like I would disagree. I mean, if you look at the literature, it doesn't seem to make a big difference, but you got to follow the protocols. And so then the thing is like, simple things like, they're trying to get their leg up on the table, have them use their hands and have them get up there or use the other leg. And then so kind of the simple things is like, okay, they can't do this. How can they do this? Or, and just so simple things that, but then I think the big thing is, it hurts to do like isometrics.
Yep.
Well, have you tried it this way or this way? I think what happens is, this is a little bit later, but squats hurt. Well, every option of squat or just squats, so I mean, because there's a multiple different ways you can change it and progress it. And so, but I think in general is the big thing is getting them calmed down early on.
Yep.
And because it's not like an ACL where you got to worry about the notch plastic, but there are some concerns, and I talk about this on the course is, they will end up with these big scars, and so that's why when you're doing the range of motion, what does it feel like? What does the within range of motion feel like? What does the infield feel like?
Yep.
I mean, if it's starting to get, if I'm getting in range and it feels like it's like we're butting up against something, how do I change it or how do I? And the other thing is, don't be afraid to ask for help. Like there's multiple times where I've called the doc and say, hey, what do you, I mean, it seems like they're really irritated. What do you think? And, maybe they'll try a dose pack or something. And, I just think it's, in general, is we tend to push them too fast or too slow. And without, versus like, looking at the patient and, is the range of motion, I mean, are they getting more comfortable? Is the range of motion progressing? What does it feel like within the range? What does the infield feel like? So,
Yeah, I completely agree. And I think some of these basics that we know about other joints, right? Just like passive range of motion and protected ranges, reversing of muscular inhibition, like they never go out of style, right? Like, and I think that's where you have to do really good diligence to your knowledge of exercise science and your knowledge of muscle activity and what exercises stress certain parts of musculature and what positions are going to stress more. And like, you have to really know the anatomy and the EMG wise inside and out. And I think when you kind of have a set of exercises that you think like, okay, this is how I do circumduction. This is how I do passive range of motion. This is how I, feel comfortable with isometric starting on. How do I get the glutes going? How do I get some of the basic stuff going? Why am I not going to do straight leg raises with this because they had a different surgery versus somebody else? Maybe you can earlier. I think when you understand the principles of rehab, passive range of motion, muscular swelling, all that kind of stuff, gait, crutches, right? Like you can put them on top of your specific patient in front of you. But I think the biggest thing that people miss is that you have to not build the train tracks as the train is driving at you. Don't expect to evaluate your patient and then have them in front of you and be like, okay, what am I going to do? What am I going to do? Like you have to think, get the op report, get the MRI, talk to that patient beforehand, plan out what am I going to do with these exercises? If it doesn't go well, what's my regression? How am I going to progress that person? I think strategically planning that before the assessment seems to help a lot of new grads kind of formulate themselves.
oh yeah, that's a good thing. And I talk about this in the course, and I talk about this with my students. Is like I use some stairs, and what's level one, what's level two, what's level three, and if you start with level two and they start getting, they need to go backwards. Like how are you regressing it and or progressing it, and even like for example, I mean, and like you talked about before, is like knowing what was done. So if something was done and they seem to have some iliopsoas tendinopathy or something, like just simply knowing that the iliopsoas runs in front of the femoral head and acts as a stabilizer anywhere from 15 degrees of flexion to extension. So like so if you try to do heel slides at 0 and it's irritating them, okay, they can't do heel slides. Well, put them at 30, put them over a bolster,
Yep.
use a towel. Now they can do heel slides, right? And so like knowing the anatomy, knowing what was done and knowing how to change it in versus like, well, they can't do squats, they can't do heel slides. Well, they can't do them that way, right?
Yeah, I think I don't know why this just popped in my head. The first time I really got that concept of like knowing what was done and where is when Mike and Lenny had presentations on like cartilage issues in the knee, like different parts of the trochlea engaging in different ranges. Like it's not that you can't use your knee, it's that like if it's on this part of the condyle, you can't go super deep. If it's on this part of the patella, inferior pole, you can't go super shallow. And it's like find ways to work around the range that engages it. But every joint, every surgery has that option of what you just said with iliopsoas or microfracture and weight bearing or issues like that. Like you have to understand how different procedures impact ranges, especially like the capsule and like ER and extension and stuff. Like there's a reason why for 6 weeks they don't want you to extend their hip too far and some protocols, right, ranging, but there's a legitimate reason. I think sometimes we don't respect that and understand why or have a communication point, and then they get angry, the hip joint gets angry early and then they get angry, I guess, as a result too. But those first 4 to 6 weeks are really like kind of sometimes protecting them from themselves and educating them about like pick your leg up, like don't slide your foot too far, like when you get out of the car, don't lean your way over and cross your body and stuff like that. Like little things like that they probably don't realize are keeping their hip sensitive for longer periods of time.
Yeah, I think like even on the shoulder, when they come into the sling, is you tell them not to abduct their arm, but they're like taking their sling off and they're pulling. Well, that's abduction, right? And so, and then pointing out to the patient, and maybe you as a clinician, is flexion is the femur coming towards the pelvis or the pelvis coming towards the femur, right?
Yeah.
And so, like one common thing that we get is people have trouble taking their shoes off, bending over and untying their shoes, and then just kind of pointing out, well, that's still flexion, and like how can you change that? And I think the other thing to realize too is like isometrics are good, right? And then doing multiple angle isometrics, I mean, they've been shown to have 20 degrees of overflow. And so, so if you're worried about them getting strength at extension and they've had psoas issues and you don't want to work in that range, put them in 20 or 30 degrees and you're still going to get some overflow in that range. So
yeah, absolutely. And I think another point you mentioned earlier was the ability to take the similar concept but switch it in terms of stuff. I find personally that someone, and Lenny's talked about this with the knee too, is like someone laying on their back and getting their leg pushed up into hip flexion when they know it's sensitive is very fearful for a lot of people. The same way that like cranking someone's knee into extension is really, really painful too. But hands and knees rock backs with the exact same angle and slightly externally rotated to 90 degrees. I can't tell you how many patients don't tolerate supine passive flexion because they're guarded, but then they do it their own control and you cue them through it and they can rock back to the exact same angle just fine, completely fine. And it's still, I mean, it's active assisted versus passive, right? But if the protocol allows 10 rock backs is the same as 10 passive range of motions, hip flexion, like just find the avenue that's best for them.
No, absolutely. I mean, I love those too. And talk about this in the course, and just the other thing is the patient's in control, right? And so I think sometimes giving the patient control and doing that kind of stuff is part of it. Because I mean, how many times have you had somebody where you're doing range of motion on them and you're saying, well, just relax, and why aren't they relaxing?
I am relaxed.
maybe it's you, right? And so but then the quadruped rocking is, and if they don't tolerate, have them abduct, have them externally, I mean, have them change those positions a little bit, have them shift to the non-involved side, and just like keep persisting and trying to find a way that they can do it. So
yeah, I think those are all very good strategies for early rehab. And I think the middle of rehab is typically not, it's usually like the glory land for a lot of people. It's like the honeymoon phase because they're not in a lot of pain. They can tolerate exercise well, it feels good. But I know you and me and Mike and Lenny and everybody else have had some discussions about like, are we really doing the athletes justice in the advanced strength and conditioning portion and then also the return to sport phase? I think personally, we're dropping the ball a lot on certain aspects of this because our knowledge of strength and conditioning is not great, or we don't have that ego check to refer them to a strength and conditioning coach. And I guess I want to end the podcast kind of going through the whole cycle here is where do you see maybe the ball is being dropped in some of the advanced phases of strength and conditioning? And, what can clinicians stay on the front curve of for not letting them go back too early when they're not strong enough or they haven't done any workload management?
Yeah, I mean, yes, I agree. I think it's, I mean, if you look at the outcomes, I mean, simply the outcomes, like we did a systematic review, meta-analysis showed that 74% of people are actually going back to the same level.
Yeah.
But then a group of my colleagues in Denmark show that only about 20% are actually going back to the same level, satisfied and performing. I mean, for the reason that they had the surgery, less, 2 out of 10 had this goal of doing surgery to get to this, and only 2 out of 10 of them are getting there. So 10 out of 10 had the goal. But, and then if you look at even non-athletes and you look at patient-reported outcome measures, like they're typically about 80%. And then another Denmark study showed that even the people that are satisfied, they're not as active as they were prior to surgery. So like, what is going on? And so, I think I mean, I think there's a lot of reasons, right? I think it's perhaps we're not as good at, maybe that's, we're not, kind of the considerations that, do you need to send them to somebody else?
Yep.
And or do we have enough time? Do we have enough insurance? I guess all that depends. But yeah, I think I mean, I like to look at Vermeil's hierarchy, and are we addressing all those things? And are we, do they have a good foundational base of capacity? And then are we progressing? What kind of a sport? If they're an explosion sport, are we truly working on velocity?
Yeah.
Are we working on speed strength? Are we utilizing energy systems? Like when my patients come in, if even when they can't do their hip stuff, like they're on the UBE or the Airdyne bike, and we're replicating work to rest ratios.
Yep.
And we're doing that all throughout the rehab, and we're building we're periodizing them essentially and then kind of getting them to the point where is eventually getting them out and assessing them for what they have to go back. The wide receiver ACL patient I had. I mean, am I really looking at him running routes and that kind of stuff? And like I could go on and on about this, but it's yeah. I mean, I'll just say one kind of story here is like I was consulting with a student and they wanted to do box jumps with their athlete and we were just kind of talking through it, and I said, well, okay, well, what's like, and it was a post-op ACL, and well, what's their quad index? Well, it's 40%, and so you want them to jump up and down off of boxes when their quad index is 40%, and they said, yeah, but it's they're this far out, and they're kind of getting bored with what we're doing in rehab, but their quad index is 40%.
Yeah.
And so it's, I think, meeting the goal, getting to a more challenging, and keep jumping, like, the recent thing right now is kind of banging on or being pro on hop testing.
Yeah.
Well, it's a component, right? If somebody's jumping the same, like the Aspetar study, if somebody's jumping the same distance, but they're using a hip synergy strategy, why are they doing that?
Right.
Do I need to work on their quads? So
yeah, and I think in there you pointed out probably the biggest thing I've learned from the ability to work with strength coaches, and Dan Pope is like a master at this, right? He was a strength conditioning coach, a very high level pilot before he became a PT. And I think that students really don't have a great, I guess, a sense of what real strength training is, and like what real strength is and how to get there, and what a normal response to exercise strength training is versus what is maybe you're pushing the threshold too far and you're putting someone into a cranky joint or something like that. And I think 9 times out of 10, when somebody comes to us at Champion and they've seen somebody else, or, they're having some frustrations for a long-term thing, like you said, 2 years, they really just don't have a basic strength program done at a 2 to 3 month linear loading basic periodization. That's a really good spread of hip dominant exercises. And we take away like 50% of the crazy stuff they're doing to themselves and say, hey, let's just do a 5 movement basic periodization program, get some energy systems in there. And they feel great. They feel accomplished. They feel like they're not hurting themselves. And somebody asked me, this is a little controversial on a podcast. They were like, as a new grad, what's the best thing that you've learned con ed wise to help you as a PT? And I was like, taking my CSCS, being a strength coach, going to Cressys and mentoring and just watching and looking and learning and hanging out with strength coaches at Champion, because normal response to exercise is I'm sore and I'm tired and this is hard, and it should be that way at the appropriate time. I think sometimes clinicians in general, but definitely new clinicians, are scared of a proper dose of strength training, and they jump to that power step or they jump to that return to sport step, and they miss the foundation of athleticism, which is strength. And I think the outcomes reflect maybe why we're having some headaches there.
I think it's hard though. I mean, it's challenging. It's, I teach in a PT program, and it's hard to cover that stuff. I mean, it's just, there's so much coming at them, and it's like anything though. If you want to learn how to be good with strength conditioning, like I did the same thing as early in my career, is got my CSCS, but I was good. I mean, my content was primarily NSCA conferences and going to national conferences and just hanging out with good strength coaches because like my programming was terrible too. And, then I think it was in 2011, Dan Lorenz and I, wrote this article on periodization, and it's like, oh my God, like it was like everybody loved it. And it wasn't anything, fantastic, but I just think it's with students and young clinicians, there's a lot coming at them, and it's with anything is you got to be in that arena, and you have to have that experience, and you have to learn how to apply it, and you have to follow somebody, and hanging around good strength coaches, and like that's where I learned all this stuff. And one good thing about the Zoom environment that we're in is like you can go to so many conferences, and like I'm attending conferences that I never probably would have attended, because they're on Zoom. And so, like Tim Suchamel is going to be doing a conference next month, and I've already signed up for it. So
Awesome. Yeah, it's such a tough. We talk a lot about this at Champion, is like the challenge that schools have to give the amount of information that they need to be. You got to be safe first. Like you can't hurt anybody, and so that's their number one priority and role. And then after that is like the advanced stuff. And while you want to snap your fingers and say they should get an entire course load in exercise physiology and strength conditioning training, and it's like the reality of that is very challenging. I can see that from the academic point of view, but then they're like, where's that balance between making sure like, okay, if I'm teaching someone how to be walking someone on a ventilator and advanced stroke rehab, like where's the little bit of strength conditioning for like the ACLs, the active people? I think it's an evolving concept in PT schools that I think is really challenging, but I hope in the next years more programs kind of balance out, I guess, their aspect. And I mean, I know you teach and you're on faculty, so I'm empathetic, but it's hard sometimes to see patients new grads who come out with like, they're all full of excitement and they're ready to roll. And then you ask them like, okay, what's the basic strength program we're going to do? And they just talk about like quad sets for a while or clamshells with a yellow band. You're like, all right, now what? Now what? And maybe the role of learning that is after school. I don't really know, but I feel bad sometimes for clinicians that are overwhelmed with how to strength train people.
yeah, no, I get it. And some program like we're doing a sports elective, and so some programs are doing that kind of stuff too. And that's kind of thought to be the place to apply that. And like the students are, I'm just speaking generally, not just our program is
Sure.
like they're getting exercise physiology, they're getting foundational concepts, and like we all did, like I did this too, and this is why I hung out with strength coaches, is taking that information and applying it. I mean, even MSK stuff. Okay, here's how you do Federer's test. Well, okay, my classmate doesn't have pain. Like what? I don't know the context of that situation, right? And so, I mean, it's like you said earlier, is okay, you can talk about early post-op rehab, and then you get a patient coming in, and they're throwing up and they're like writhing in pain. Like Reiman didn't talk about this, and it's like this is not in his book.
That's awesome.
So yeah, I mean, I think is part of just being able to relate to patients, and taking all the craziness in, and staying calm, and like, okay, I still this is the anaerobic energy system. Okay, what's the work to rest ratio? What kind of reps and sets do I want to do? I mean, is this an experienced person or non-experienced? Like I can probably do 3 sets of 10. I mean, that's probably not a bad thing, right? So yeah, there's just a lot.
Yeah, I completely agree. I used to, early new grad, I would take the side, obviously the clinician, and be like, oh, I didn't get taught enough. And then I got farther out and I was like, watching a program try to develop its curriculum. I'm like, this is hard, man. This is really hard to get everything you need to know, especially with how much base knowledge you need to build before you even talk about like an elective, as that way. So I'm empathetic to both sides for sure. Well, I don't know. That hour and a half just blurred by. I could talk to you for hours, Mike. I really think it's phenomenal to chat with you from all sorts of ways we were diving around the conversation. But I definitely want to shout out your course, and I want people to really take that. I think the online stuff you have is phenomenal, so I thank you for that. But anything else you want to share about hips in general, or just advice to new grads, advice to grads around the world? Anything else on your mind?
No, I mean, I think just be around good people, right? And in general, and I mean, kind of the reason that we started, Rehab Learning Center. I mean, we have courses on hip, we have courses on how to do a subjective exam, courses on overdiagnosis. So, I mean, it's more than hip, but it's try to create a community in it. I mean, seems to, kind of like community, like you guys are in just online, and I think if you'd ask anybody, that's experienced, they'd probably give you a lot of different pieces of advice. But I think one thing that's probably fairly consistent is be comfortable with being uncertain, and then just be around people that will help you and give you valid criticism that is helpful.
Yeah.
And it's like I just finished my PhD 3 or 4 years ago, and I was pretty established, and like I got some good criticism that was extremely helpful for me. So
Yeah, I couldn't echo that more. That Mike always puts that graph up, but like what you think you know versus what you know, and how that goes as you kind of go through your clinicianship and stuff like that. So anybody who's 1 to 2 years out right now is probably real fired up, and then you get to my spot where I'm like 8 years out, and I'm like, whoa, I got a lot more to learn. Then you get farther along the journey, and the more things you answer, the more questions that evolve from it. So yeah, great people around you, great environment, being willing to always ask for help, contradict your own opinions, grow with the evidence. I think those are all really sound pieces of advice.
yeah, I think I've been through Dunning-Kruger like 3 or 4 times. So.
Yeah, I'm on the next page down the road of well, Mike, thank you so much for your time. I really appreciate it. And then we'll put this together and probably put it out in like a month or so.
Yeah, absolutely. Thank you.